I was going to talk about something I talked a lot about at as a member of the MRT Housing Committee, which is the need to develop a single point of access for people who are accessing MRT housing, to be able to track it, to be able to prioritize, to be able to match housing with prospective tenants, because like even now statewide there are 5,000 units and there's not really a tracking system. But then I thought I'd rather do sort of a provider's perspective and be a little more granular and talk about stuff at a systems level. And and what it feels like as a provider, in the whole changing field, and what, what, at least at CUCS, what we're trying to do. Jason Helgeson had talked this morning, if you went to his workshop, about, organizationally trying to find your place in this. And I recently saw an ad for what I assume is a Caribbean music group called Jamaican Me Crazy, and it made me think of the MRT. If only because of the language, that's getting, the new language that's coming in, whether it's health homes, which are not really homes, HARPs, DISRIPs, PPSs, FIDAs, IPAs, OY, OI, and so, that aside, I think what all that's doing is it really is making us pay more attention. It's begging us to pay more attention to the health care needs of the people that we serve in supportive housing, and integrating our other services like mental health services and substance abuse services with primary care. So that's what I want to talk a little bit about today. And at CUCS, for a variety of reasons, we've been actually tracking the health care utilization of our supportive housing tenants. And we've been doing that for 6 years. And I'm going to show the data from the most recent one we did, because I think it's be interesting and some food for thought. So I just want to preface this by saying that this is really intended for internal use. It's not sushi quality. We're not going to publish this. It's retrospective, but we do have a lot of faith in the data. So what you see here, the inclusion and assumptions, these are, most of these properties are the properties of our partner Common Ground. And then there's what we call the Uptown sites, which are the properties of Broadway Housing, another partner. From March 2011 through 2/29, it's a full year. It's only people who have been in the residences for a full year. And these cost assumptions are, we think they're pretty close. There's not a lot of good data on cost assumptions. We got some of this off the net. We've confirmed this with experts in the field like Dr. Brenner. So we think they're pretty close. So we're going to talk about utilization and what the costs are. So let me just tell you what we consider institutional care. It's medical inpatient, which I had up there, right? It's psychiatric inpatient, medical ER, that's non-admit, psychiatric ER, non-admit, inpatient, residential substance abuse, and nursing homes. So most of the people in our residences are chronically street homeless. Common Ground CUCS made a commitment beginning in 2007 that all our vacancies would go to people who are chronically homeless. And so one of the things that you see here is that 32% of the entire sample, only 32% use some kind of institutional care during the year. And remember, all this happens to predate health homes. It predates all this discussion. So what this speaks to is, says something about, the kinds of institutional care that people are using, at what level, but it's also, I think, it's a testament to the supportive housing services in supportive housing. Because people move into supportive housing, and like Liz says, housing is part of health care. And, obviously when people are on the street, they were using a lot more, they would likely be using a lot more institutional care, but 32% is relatively low. And it goes to what the supportive services staff is able to do on its own without that. There were 20 tenants, and this is less than 3% of the entire sample, who used upwards of $125,000 of services and an average of $289,000. So now, because we, as those of you who provide supportive housing and services, we know the tenants. You know them because you live with them. And so we could really go through these cases and see what these cases are about. And for the most part, there's some sway in here, but for the most part, what typifies this group of people is not that they're currently substance abusers, not that they're currently alcoholics, but that they were. They had very hard lives on the street, they were using a lot of substances, and this is sort of the aftermath of it. That's primarily what we're seeing within this group. The estimated cost of the institutional care of all of these people was about $10 million in that 1 year. And one of the things you're also seeing is that close to $7 million of that $10 million was for primary health care issues, and less than $3 million was for psychiatric, which, as the person on our staff who puts this together, Aaron Levitt, said, no matter how bad things are with your brain, your liver is always more expensive. So these are just to give you an idea of what ails people. You can see, so the one is the full sample of the 725, 152 of have heart and circulatory problems, and then 31%, were going in institutional care for that. What's interesting also, in addition to what the issues are for people, it's the number of diagnostic classes. So in other words, what that means below is if you have one or more than one of the diagnostic classes, it's 121 people. So what this is suggesting is that of the sample of the 725 people, significant numbers have more than one chronic illness. So what has this meant to us? So some of you might know that CUCS has a program called Psychiatric Outreach for the Homeless, PPOH. And what that does is we have 19 psychiatrists on staff, 10 are full-time. And we make psychiatrists available in settings where they would not otherwise go. So we have psychiatrists in soup kitchens, shelters, supportive housing. They work with the street outreach teams, because typically psychiatrists don't make house calls. And organizations have difficulty recruiting psychiatrists, for the 2 or 3 hours a week that they need them. But if you're involved with mental health care, you know that without a good diagnosis, it's all going to go awry. And people are shaking their head because so you need a good diagnosis. And you also need a psychiatrist, because you got to fill out the right forms to get into housing if you have a serious mental illness. And so that's what we're doing. So, and that's been very effective. And it's in 50 settings across the city. So a couple of years ago, the light bulb went off, partly, thinking about the MRT and so forth, and CUCS is also involved, with, doing a health home. They said, well, why not merge primary health care with psychiatric care? Bring primary health care to the same places. Bring primary health care to supportive housing, bring primary health care to the street, to soup kitchens, and let's see if we could ramp that up. Really kind of like the black bag model, right? The old Dr. Welby, going out and seeing people. For people who, within these groups, people who are not accessing care or they're getting inadequate care in the community. Those are the two targets. And so the organization, the affiliate now that we have is no longer PPOH, but PPOH is still part of it. It's called Hannigan Medical Care. And the way that it's set up, it's actually Hannigan Medical Care PC, and it's a captive professional organization. And the way that it's set up is probably much like if you have a physicians group, they are a captive professional corporation, typically of a hospital or something like that. And it's a doctor's practice. And so that's what it is. And that enables us this freedom to go into different places. And so right now we're in 8 settings. We have some private money to sort of ramp this thing up. And referencing what Jason Helgren said, like seeing where we can fit in and what we can do. And this group of people, in supportive housing, and those who use institutional, and how they're using institutional care and our ability to keep them at institutional care, is, partly for them and obviously and partly for the cost is what we're doing. So I thought what I'd do is just close with, reading a couple of cases, brief ones, that I got from our staff, because we now added a primary care physician who's happens to be both a family practitioner, and she's also a psychiatrist, and 2 nurse practitioners. And so we're beginning to ramp this up. And so I'll just, to give you an example of what we're trying to accomplish. And, and I'm assuming you have, these types of individuals in your housing settings also. So case 1 is and I got this directly from the notes, a 40-year-old female, formerly chronically street homeless with diabetes and grossly uncontrolled blood sugar levels at 14.8. Normal is 6. Uncontrolled hypertension, grossly uncontrolled lipids, which is cholesterol, morbid obesity, history of crack cocaine abuse, now abstinent. So you can see that, like I was saying. When she first presented to on-site medical care, she had been receiving fragmented care from various ERs, hospitals, and providers. She presented with huge amounts of medication bottles from various providers with many adverse drug interactions and class duplications, as they were all coming from different providers. Patient was confused, unable to decipher what her regimen actually consisted of, and thus unevenly adheres to the meds as was too confused and fearful of side effects and interactions. On-site nurse practitioner has spent hours with the patient reviewing medication regimens, simplifying it, reinforcing it, going over interaction checks, all to gain the trust of the patient. Now the blood sugar level dropped from 14.8 to 9.4, which is getting better. Blood pressure is now under control, lipids improving, though not yet at the goal. Patient is able to explain her med regimen and rationale. She attends the on-site gym to meet with a fitness trainer. She has stopped eating 3 bags of corn chips daily, now only eats 1. And she has attended every single health maintenance appointment. So you can see where, like, a case manager could now start to take this over, but why a case manager, couldn't do this from the beginning, wouldn't really understand her medications, really wouldn't understand, but could then kick in, and now the person's sort of oriented about their medicines. I'll just read one more, and this is a very recent case. I changed the name, obviously. Mr. Guy first presents to the clinician with very high blood sugar levels, very high blood pressure, high cholesterol, and severe vitamin deficiencies. When he first met with Mr. Guy, he recognized that he had a very low-level understanding of his conditions, as well as cognitive limitations and mental illness with very tangential thought processes. Mr. Guy mixed up high blood pressure and high blood sugar, even believing they are one and the same. He took medication sporadically and believed taking too many pills was not good for you. In a busy clinic setting, which he also attended sporadically, the 15-minute visits and quarterly follow-up protocols were not working. Mr. Guy got lost in the shuffle, and these inconsistencies were essentially left unaddressed. For the Janian practitioner, his medical conditions were so out of control, it was difficult to prioritize which conditions to treat. They began by compromising on a plan and decided to meet every week to check his blood sugar and blood pressure, as well as to keep learning about his conditions. After only 4 weeks, he has marked reductions in blood sugar and agreed to restart his blood pressure medications. He also began to recognize the risk of high sugar levels, the connection between lower blood sugar levels and the increase in diabetes medication. So this is where we sort of, as I said before, where we're finding, there's a need. And as I said at the outset, it is, we're really getting closer to what the needs, the healthcare needs are, and the patterns are of our clients. One case I wrote, which I won't go into detail, which was pretty interesting, a woman who had a very long history of heroin addiction, and she's got all these medical problems, and she will not go to community care because she feels that when she goes there, she's also mentally ill, when she goes there, that everybody's looking at her and they think that she has all these problems because she was a heroin addict and the stigma of being a heroin addict, so she'd rather not go. The bad feeling she has just by being there is overwhelming. So we've now, she has, really major bronchitis and COPD issues. We're treating that on site. Again, high blood pressure on site. She goes to methadone, but if she has too much pain, she uses heroin. So now, we're doing pain management and getting her a car and so forth. And eventually, this is the type of thing you could also flip over to case management. But we believe that there's a place for new models of medical care, and that's what Janian is. That's it. Thank you.